to talk about a new protocol this year that's being implemented, and it's patellar dislocation reduction. So thank you, Dr. Shertz, for being here. And let's talk a little bit about kind of when we're going to see this and the protocol itself.
Certainly. So the first thing to know about this protocol change is this is an entirely new protocol. Although patellar dislocations are not uncommon, they're certainly not super common. And the kind we're going to talk about reducing pre-hospital, it doesn't have to be reduced. So if you have any concern about doing the procedure, there's anything that kind of just makes you a little nervous about it, it's not a big deal that this gets deferred to the hospital. But you can save your patient some pain and some inconvenience, or some discomfort, I should say, by reducing it pre-hospital. So the first thing we need to do is we need to acquaint ourselves with our anatomy. So you've got your distal femur coming down to your knee, you've got your kneecap or your patella, and then you've got your lower leg, which is your tibia and fibula. So your kneecap normally just articulates in this groove. When your patella dislocates, it slides usually laterally, and that's one of the keys of this protocol, is we're only going to think about reducing lateral dislocations. If the dislocation's medial, that's usually some major kind of trauma to the knee, and that's much more associated with fracture, and then you just want to leave it be. So what'll happen is when this dislocates, the shortest distance for this patella with the patellar tendons is actually off to the side. And so you'll have a patient that presents with their knee flexed, the patella laterally, and when you feel this, it feels really weird because you're actually feeling parts of the knee you don't ever touch, and that's going to be what a lateral patellar dislocation is going to look like. Now, you can probably already intuit that if I straighten the leg, this is going to snap directly back into place, and that's exactly the procedure. So to talk about some other details, indications, you have an isolated, non-traumatic lateral patellar tendon dislocation. If something hit the knee, they whacked the knee on something, that's going to raise your likelihood of fracture. I would just leave it be.
And any injury above or below, any femur, tibia?
Anything that makes this more complicated.
Right.
If it's not just an isolated, their kneecap is off to the side laterally, I would not pursue this. You're not gaining anything.
Okay.
So they're going to have pain with this. They often get a lot of muscle spasm. It's not unusual for these patients to get some degree of fentanyl, although admittedly, once they're popped back into position, they tend to have very little pain. So how we're actually going to do this is, again, if we think about our model that the patella is anatomically in its shortest position laterally, once the knee straightens, it'll snap back. Keeping the patient in this position with their lateral patellar dislocation, you're just keeping them dislocated. And often what happens pre-hospital is the knee gets straightened, and by its own force, the patella just slides back into place, and that's okay. If we're going to reduce it manually, when the knee is flexed, we're going to be prepared to straighten it, and at the same time, push that patella the direction it wants to go. But it doesn't take much of a shove. It wants to go there anyway. And as we straighten this knee and just push it medially, it almost always snaps back. And then they have a full range of motion in their knee. We'll attach a short video where you can actually see this being done. One caveat on the video, though, is they reduce that dislocation mostly by pushing with the knee bent at an angle, and I would highly recommend, per the protocol, straightening that knee, because then you have more mechanical advantage. It'll literally almost reduce itself.
Okay, real good.
Couple other things to know about this. Even with the non-traumatic lateral dislocations, you do occasionally get fractures. You will have patients that say their knee's completely fine and they don't want to go to the hospital. That's going to be a refusal, because we do see that. Realistically, though, it's a very easy thing to do. It's more dramatic in appearance than serious. My final plea on this is a knee dislocation is when your femur and your tibia and your fibula are actually physically dislocated. That is entirely different than when your kneecap or patella is dislocated. And the way that gets worked up in the emergency department is very different. When you have a knee dislocation, your popliteal artery that runs in the back of your kneecap gets put under shearing force, and you can actually have that get so much damage that if it's not diagnosed, you can lose your leg. Right. That is very different than a patella dislocation. I have had patients that came in with patella dislocations that were called knee dislocations, and we need to understand the difference there because they're treated entirely differently. So again, a patella dislocation, hold that for me, your patella should be laterally displaced, and that's it. Everything else should look pretty normal. There doesn't tend to be a lot of swelling. There doesn't tend to be a lot of ecchymosis. Straighten it, give it a little shove, it'll relocate itself. Perfect. And it's really that simple.
Okay.
Today on Fracture Fridays, let's talk about how to reduce a dislocated patella.
So usually the kneecap is dislocated when the patient hyperextends their leg, like landing from a jump. Almost always you're going to see it displaced laterally and the patient is going to flex their leg. To reduce it, you're going to firmly grasp the patella, yes, firmly grasp it, and simultaneously, while you're rotating it back medially, you're going to straighten the patient's leg out. As you can see here, it pops right back into place, and generally the patients are just a bit more comfortable after that's done. You'll want to provide a splint for comfort, crutches as needed, and then they can follow up with their primary care doctor, an orthopedist, or sports medicine. While doing this procedure, it's probably a good idea to provide a little bit of pain control as well.
So take a look at the protocol, look to your training divisions for a little bit more information, and again, please take a look at the contraindications. This is again just isolated lateral and no other trauma.